Good afternoon, everybody, and welcome to this week's Power Hour. I just want to remind you that the Power Hour is an effort that comes to you, offered by the Keenup Institute for Physician Leadership, and it was a way to really focus on community, collaboration, and conversation. And we will keep this effort going for the next few months, every other week, and as we hit the fall again, we'll probably go back to weekly format. So we hope to see you again and come back and participate again. And we do invite everybody to participate in the audience as well. And you can either unmute yourselves. We will ask you to keep on mute when you're not talking. But you are welcome to engage with the guests and unmute yourself and ask a question. Or you can put your question in the chat box and we will get to that as the flow allows for that in the conversation. Other than that, I'm going to hand over to my colleague Franklin Walker, who is, as always, our eminent moderator. Thank you so much.
And welcome everybody. We again, as Tina continue our discussion today about racism and what we can do as individuals to help alleviate inherent racism and health inequities. And we have a few folks, Drs. Brown and Dr. Smith, who were with us on June 5th when we started this conversation, and we've added some folks. So I think we're going to have a great discussion today. And a lot of things have changed, of course, since June 5th when we had that initial discussion. So I want to get started today. We're going to talk about, as I said, racism, health and health equity. Also want to talk a little bit today about what the North Carolina Medical Society is trying to do to alleviate some of these things. I know that our policy committee recently released a statement on how it intends to address health inequity. So I've given this out to our panelists today, and I want to hear from them what they think about our initial stab at this, and does it go far enough? Do they have any suggestions? And how we might implement it and where we might implement it. And so I think I'd like to start out with Dr. Phil Brown, who is one of our board members and incoming president for the North Carolina Medical Society.
I think that the policy as recommended is a good start. Most definitely open to hear enhancements from this group because the board hasn't actually voted on it yet. This is, I think, a policy recommendation at this point, and so there would be time for enhancement. The thing that I would say that I feel the most strongly about in the entire statement is that the policy committee has recommended that it be prioritized. And I think it's really timely, overdue actually, but critical for us to begin to make some changes that have needed to have time.
Super. Dr. Dawkins, you're at Wake Forest Baptist, so you probably have a little bit different take on our policy, but I would like to hear from you.
Thank you. Thank you, Dr. Walker. Thank you, all of the organizers of Power Hour, and thank you for this opportunity to be able to participate. And yes, so I do have, and I'm looking through it. So I agree with Dr. Brown, and I think it's great that the North Carolina Medical Society has taken this step and has wanted to prioritize it because it is very timely, especially with all the things that are going on. And so having said that, and so I just wanted to share those few points with you all because it's more like an acknowledgement than a call to action, which I think it would be important for the North Carolina Medical Society to have a call to action. And outside of listing the North Carolina Medical Society, there are no specifics on who is responsible or accountable for upholding this policy. Is it physicians? Is it department chairs? Is it hospital CEOs? Is it advanced practice practitioners? I think for the policy to be effective, it needs to name who are the one out this policy. Additionally, there's no language about who's accountable for removing barriers once they are identified, because there are barriers that keep racial inequity intact. And so once they're identified, someone's going to have to facilitate removal of them. And also, I don't think the statement goes far enough. It's a bit nebulous. And I think for each part of the policies, the writers should ask themselves, how are you going to show that the North Carolina Medical Society will not tolerate sexism or discrimination in any realm? And what does that mean? What does that look like? And I think once the board asks themselves those questions, then the answers should be infused back into the policy. And also, as far as an example of what a good statement is, I'd like to call to your attention, the ACGME put out a diversity statement that went into effect July 1st, 2019. And not to insult your intelligence, but I would like to read it. And it's page 5 of the ACGME Common Program and Requirement C. And it says the program, in partnership with its sponsoring institution, must engage in practices that focus on mission-driven, ongoing, systematic recruitment and retention of a diverse and inclusive workforce of residents, fellows, if present, faculty members, senior administrative staff members, and other relevant members of its community. And it goes on to talk about assessment. And so I think if the North Carolina Medical Society could put the teeth and the power that it needs to have. Thank you.
Well, Dr. Dawkins, I want to thank you for that feedback and commentary, and I'd also like for you to share that document that you just read from with Tina and myself, and we'll make sure that gets in the right places.
Absolutely.
I want to come back now to, thank you, to Dr. Karen Smith, who's also a board member with Dr. Brown at the Medical Society. Dr. Smith, what do you think?
Very good, and thank you again for everyone for participating and all of our listeners. I certainly agree with Dr. Dawkins in the fact that it does recognize, but there's no specifics in terms of act, what should happen. And I wrote one big word on top of the policy, bodacious. It is an act of bravery to disrupt the status quo and to now either dismantle and absolutely create what it is that we hope to achieve. We also recognize not everyone is in the same level of understanding, and that there will be quite a bit of education. We recognize North Carolina Medical Society is a healthcare organization leader in our state, and we will have others who will not only be our audience, but they will also be participants in terms of that we hope to achieve. We look for individuals to do more than just survive healthcare. We want to see every person be healthy and thrive in their environment. And our policy can certainly be created to reflect that. But we start with self. And it's going to position our mid-level PAs, nurse practitioners, our staff to look at self when we are reviewing that unconscious bias, and to create a policy starting with self. But other than that, I truly appreciate the comments. See my notes, you will see where I have underlined many of the same words that you have already highlighted for us.
Super, thank you. I'd like to get Laura, who's actually a PA student. She's at a different point in her career than the other three folks that we just talked to. Laura, can you chime in on this?
And thank you all for having me here today. I'm going to agree with Dr. Dawkins and Dr. Smith. Actually have the exact same points that I thought it was, the same was hard. It acknowledged that health inequities are real and they're rampant to the point where policy needs to be created in order for it to be addressed. However, there was that I could see or detect from it, or from my standpoint, associated timelines to show what in the ways plans to dismantle structural racism, how we're going to create solutions. And so those were the holes that I also saw as well.
Super, thank you. I want to talk about something else now. On, I think it was June 9th, just after our former conversation, Governor Cooper established the Task Force to Racial Inequity in the state criminal justice system with an executive order saying we must acknowledge racial inequities in our systems of law enforcement and criminal justice and then work to eliminate them. So that is talking about the criminal justice system. So my question is going to be to you all, if you were tasked with establishing a task force to address racial inequity in healthcare and medicine, what would be your top 5 priorities? And which entities would you want at the table, okay? And so, Dr. Brown, I'm going to get with you on that first, sir, if you don't mind.
I think one of the most important things that we have to understand is how we demonstrate success through action. And so what that says to me is that in areas where we can get maximum alignment around health, those are obvious places to start. And we have the Healthy North Carolina 2030 health index, very aspirational, but they stand the chance of being able to align us around. Because if we were to act in a cross-sectional manner across the entire community, the whole state, then what we could, we could make some deep inroads, and we could possibly move North Carolina within a decade from our current 36th ranking in overall health to probably the top 10. But it requires taking action immediately and relentlessly for the entire course of the decade. But all those things are in that report, and they're, again, the reason it works is because they're across all sections. You have criminal justice pieces, you have economic pieces, you have educational pieces, you have pieces that are directly related to healthcare. And so they're actually an opportunity for many different organizations to grab onto something and move that ball. But to me, more specific areas we would attack is that we really create alignment around attacking them and instead of talking about it for another decade.
Great. Michaela, I haven't called on you yet, but you're in a unique position, I think, maybe to comment on this because you're a population health manager. So you are collecting a lot of data that might really be relevant to this. So can you chime in on this subject?
Yeah, absolutely. And thank you for having me. So based on that we found in our office, I say one of the things that serves as a barrier to health for a lot of our patients is access. And there is a major difference between different racial groups that we've identified, whether it be access in the form of transportation to and from appointments for different providers. But the one that I have noted significant impact has been insurance. So gaps in insurance. So as a population health manager, it's my position in the office to encourage our patients to take care of their health in the form of preventative measures. So we'll have an insurance company saying, we want our patients to have that colonoscopy, that mammogram. We want them to have all of those preventative measures based off of their diagnoses and their demographics. And that's fine. But then, you reach out to the patient, tell them your insurance is recommending this, Dr. Smith is recommending this. There becomes a barrier of, I can't afford my copay at the specialist office. So there are things that have to be addressed in order to promote equity in healthcare. What is actually taking place within our patients is where we need to start in order to create a list that will be reflective of the change that needs to occur.
Super. Thank you for that. And Dr. Dawkins, do you want to address that
Yes.
as well from your
Yes.
perspective?
And
Okay.
you're welcome.
Thank you.
And you already challenged me because I listed about 12 priorities, but I did pick out 5 while I was listening to the others. So the priority for the task force itself, I would recommend that it's ethnically diverse and includes at all health profession levels. I think a lot of times when, far-reaching changes are made, but people at all levels are not included in that decision. And so it's just effective because the people at all levels just are not there. And so they could give that piece of information that might be the game changer. Second is giving the task force power to implement changes. There's no frustrating than having a group of folks who are tasked to do something, but they have no power, they have no decision-making ability. It's pretty much a sheet of paper that's going to go in somebody's file and nothing. So this task force needs to be able to appropriate changes. And someone, I think it was Dr. Smith, mentioned that this work is disruptive against ways of thinking that different people have had for years. And it's going to be disruptive doing something different. And so there may be people who don't agree with what's being done. So the task force should be able to address those issues in some form. A third, expanding and funding pipeline programs into the K and undergraduate education, because if there aren't enough minorities in the pipeline, if there aren't enough underrepresented minorities, then the North Carolina Medical Society is opportunities to put more into the pipeline, because there are more underrepresented physicians. It's likely that health disparities percentage-wise will decrease. Fourth, having as much funding as is necessary. Often when there's diversity work, all of a sudden there's no money, whereas if it was something that impacted the Caucasian community, there's just money everywhere. So, but making a difference takes funds. And so having funds that are for whatever the needs are is important. And fifth, ensure that grant makers don't discriminate against research ideas submitted on topics related to racial injustice. So that would be my answer for priorities. And it was a 2-part question. What entities would I want at the table? So I would have program directors and program coordinators. And I'm speaking from my perspective as I used to be a residency coordinator. Now I'm a program manager that oversees 3 or 4 educational programs. The program directors and coordinators are the boots on the ground folks. They are in direct contact with the future clinicians. They have impact on their curriculum for 3 to 7 years, whatever the length of the program is. So they would need to be at the table because they have valuable input. Decision makers, again, and those who create curricula, because if this is a new way of thinking, that new way of thinking needs to be infused in the curricula that our doctors, our future doctors, are learning. Designated institutional officials should be at the table. They are the ones who are responsible for graduate medical education programs at their respective institutions. So they directly have a say and they have influence to make changes. And I would also say senior hospital administration, underrepresented patients, which Michaela alluded to, as well as, if I'm getting care, I'm a great person to tell you what works and what I would like to see. Clinicians, and also our staff, because again, this is disruptive and it may involve personnel issues. And so HR will be at the table to help to determine what appropriate consequences can be taken if that is the route that has to be taken. And finally, to collaborate with those who are already doing the work to call out and eliminate racial injustice in healthcare, because they may already have protocols and processes in place to help bring real change, and they likely have networks to get things done that are already in place. Thank you.
Okay, super. Tina, don't we have a question in the chat you
We
wanted
do
to
have a
ask?
question, and it is a question.
Okay.
What is the role for families and youth in the task in a meaningful way? And this is Dr. Jerry Mattson. I think she's on, so I don't know if Dr. Mattson, you would want to chime in on this question as well, or just open it up for the guests.
This is Jay Mattson. Thank you. I don't have much to add. I know Dr. Dawkins just mentioned a little bit about that, but I guess I'm kind of curious of how we may often have families and youth in very scattered ways, and I guess I'm looking for how that can be incorporated in a meaningful way. So basically the community and the patients that we're serving and ideas for that.
It's amazing what resources we have in communities, yet we don't tap into them. And utilizing focus groups, let's hear what the patient's thoughts are. What would they like to see different, and how can we actually implement those changes that make sense for both the patients and the facilities? As a private individual, we don't have the layers of the different individuals we can turn to. So oftentimes we find ourselves being quite creative. One of the areas of concern is access. But that's access is one of the quadruple aims. We want to make sure that we're providing quality care. We want to make sure that that care is efficient. And then is that care cost effective as we move more into the ACO world or the shared savings world in terms of the payments side of it, to have the patient's voice at all levels, whether access, the quality of care, the cost of the care, the efficiency of care, because we are shaping and molding systems that will launch forward into our future. Now, the biggest issue that we have right now, we had not paid attention to the racial equity. And now is an opportunity as we are constructing our systems to make sure that we are providing care for everyone who utilizes our facilities, our offices. It's an opportunity to make a change that's going to have an impact across the board for the community.
Thank you, Dr. Smith. I want to move on now and get some feedback from Laura about your background. I know that you worked in Guyana, Nigeria, domestically with hospice, Habitat for Humanity, as well as being part of the Minority Association for Pre-Med students prior to your PA training. And you've got such a diverse and worldly background for being such a young person, which is awesome. And I'm wondering how some of those experiences have shaped your view on racial bias and health equity, and how you might make suggestions based on that. Laura?
Okay, sure. Thanks for the question. So first thing I want to start off with is that I grew up in a predominantly African and African-American environment from K through 12. So from elementary school, middle school, high school, and I had teachers from multiple backgrounds. And so this is how I thought the world looked. It wasn't until I began my undergraduate career at Duke that I encountered my first experiences of implicit biases, or where I had my first experiences of microaggressions, micro-invalidation, a friend of mine. And these things that happen so often, they chip away at your dignity, they chip away at the esteem that your parents and the people that love you so much have worked so hard to build you up. And so what ended up happening for me is that I ended up majoring in international comparative studies, minoring in cultural anthropology, and continuing on at a pre-med, pre-healthcare profession track. And I did that because I needed to find space and who I felt like could support and value my voice. So my work abroad and my PA work domestically basically kind of gave me language to describe what I had experienced and what so many others have been experiencing in regards to racial biases. And later on, as I continued on with my clinical education, it gave me language and opportunities to view health inequities. So prior to going to Duke for my undergraduate, having my undergraduate experience, I was a nursing assistant in a number of different. Then after I graduated, I became a scribe in multiple facilities, and that's where I saw health inequities in action. And to be honest, as a flow or as someone who was participating in somebody's care, it was scary because I constantly wondered that patient could have been my mom, it could have been my father, my brother, it could be me. And with the power dynamic that was going on with me as an aspiring healthcare provider, trying to get into PA school, now working with this surgeon, or I'm working with this ED provider, or I'm working with this PA, or I'm working with this nurse practitioner, it felt hard to know, like, should I say something? What should be done in this situation? And if something is said, what will happen? And so what I think that these experiences did for me is that it put it in my face, and it made it very obvious. It was all uncomfortable for me. And as I continued on with my clinical education, being now in my second year, about to graduate, working with the KIPL Future Clinicians Clinician Group, it gave me an opportunity to now say, what solutions can we enact in order to mitigate these occurrences, right? And so some of the things that I've been able to kind of glean from all these experiences is the importance of the healthcare training programs. I think Dr. Dawkins definitely mentioned ways in which that we can in the healthcare workforce now, but I think we also need to focus some on how we can mitigate these occurrences in the future. Especially for me as a PA student, we're graduating in 2 years. So people are becoming healthcare providers very quickly. And that's particularly, so I think that this is very important. So something that we can do this is by addressing implicit biases that people may have coming into a healthcare training program. Now, these are biases that people may have developed throughout their entire lifetime. They may not even know that they have them. And so first we need to acknowledge that, and that needs to be part of the curriculum, especially when we're talking about healthcare disparities, health inequities. What's at stake is more than just someone's feelings. What's at stake are people's lives here. And so it's very important that we introduce this in the curriculum. It is important that we are also ridding biases from healthcare curriculum. So for example, if the topic is HIV, the first image on the slide should not be a Black male. So you have these different biases that you see in curriculum that are, so they do is that they establish stereotypes that people already have into school. Other things include pipeline programs. So many of us may know that we may have decided who to be and what profession we wanted to take part in as early as elementary school. Can we establish these pipeline programs earlier on so that we can increase diversity in the healthcare professions? These are things that are very important. So I could go on and on, but that's a summary of my experience and how I believe it has framed what I think needs to be done. Rupert.
Well, I want to thank you. That was good stuff to take away. Dr. Dawkins, I do want to come back to you and your role as the founder and program manager of the Kennedy Hopkins Scholar Mentor Program over at Wake Forest Baptist, because I think this is a good segue into what you're doing based on all the great information that Laura provided to us. So can you give us some background on the program, how many residents are involved, kind of outcomes, goals, etc.?
Yes.
Please, ma'am.
And before I start answering the question, Laura, you were spot on with what you talked about, and the struggles sometimes as African Americans, especially as we advance into different positions of what does speaking out look like. But there's one thing that I really like that our Inclusion and Diversity Office is doing. They created a training series called Active Buying, and it gives you language for how to interrupt these different instances of incivility, is how they refer to it, whether it's sexism, whether it's racism, whatever it is. And it takes into consideration the power dynamic, because you have to consider that, because there is a power dynamic or repercussions to our actions. And so it's important to be strategic in how you speak. But yeah, what you said really resonated with me, so thank you for sharing. So it's role with the Kennedy Hopkins Mentor Program. Did a little bit before 2016, and it was something that arose out of, well, not out of, but as I was in my doctoral program, is something that I considered and developed as I was going through my doctoral program. So just to put things in context, at the medical center where I am, there are over 700 residents at the medical center, which is why it's so important to have program directors and coordinators at the table, because there are a certain number who graduate every year and go out into the work. But 64 of those 700 this past academic year were underrepresented minorities, and those include African American or Black, Hispanic, or Native Americans. So it's already just 9%. So, a couple of years ago, we compared our numbers of underrepresented minorities to the AAMC's standard for numbers, and for at least for the Hispanic and the African American group, we were below what the national standard were. So already had our work cut out for us. But as an African American and as a RC coordinator, just viewing the ethnicity of residents and fellows, there was a disparity as far as, rather I should say, there was lack of diversity in the residency and the fellowship. So backing up a little bit, so far 20 learners into the program. And so, just saying again, the total residents, 64 underrepresented minorities, 20 have been matched into the program. One of those 20 has graduated last year, 3 last year. There are 28 incoming underrepresented minorities that we are in the process of matching. And so we are gaining in people knowing about us, people wanting to participate, and we're going for a year. So again, so in addition to seeing that there was lack of diversity of the residents and fellows, there's also was lack of diversity in the faculty. We had our first African American in the training program, and the program was established in 1969. And he just recently graduated, which is just a win in so many respects. We matched our first African American female in this past match, and so she started July 1st. So it's really exciting, but it's kind of like, wow, 2020, and this is what's occurring. So we still have work to do. And so just kind of thinking about those things in my mind, and it's not only my department, but departments, the lack of diversity with faculty and residents. And 2 passions of mine are leadership and mentoring. And so a lot of mentoring, just natural mentoring opportunities are based on race because of the commonalities, those shared experiences. And so those diverse would kind of miss that, because they wouldn't have that natural affinity for someone to put them under their wing and show them how they do things and, perform in the program, but just to kind of walk with them through the program. Those opportunities were limited. And I saw this over and over, and I couldn't let that go. And so I started talking about it, and I was able to submit a proposal to start this program. I also heard stories about how minority residents within and outside of the medical center had lack of support, mistreatment, differing expectations, and harsh consequences. And sometimes it would be, well, so-and-so resident, I don't know where he is. And it's like they were dismissed or whatever, and nobody knows what happened. So it's like, how can we have somebody here and then nobody knows what happened to them? So just a lot of things that I saw that I couldn't let go anymore. And so I submitted a proposal, and but I want to say that this program would not have been put on the map without collaborations with many of my colleagues across the institution. And if you look at any organization, if you're going to have a successful organizational program, you have to have buy-in at multiple levels. So I got to give a shout out to those who lended their, as well as their position to help to put this program on the map. And so that's kind of the background of it. So the 3 tiers of the program are, we do the mentor matching, early educational series where we feature either internal speakers, and then we facilitate community engagement opportunities. And so as far as the outcomes of the program has created a platform for other groups doing diversity work to collaborate. Has been one of the most important factors. So we launched the pilot of the program, and we piloted it in departments in March of 2018. And that next July 1st, the CEO declared that year the Year of Diversity. So that allowed us to really get some traction and really bring attention to the lack of diversity was prevalent in our organization, and how our CEO was committed to making a change in that regard. It's been a catalyst for positive change. Since the program has been implemented, there's been a coming together of those same diversity work. We've had 2 second look activity weekends to where we bring back underrepresented minority candidates to let them know that we care about them, we appreciate them, and we want them. And that's one step, but we also have to work on our environment that they come to. So it is a work in progress. Also, I secured a comment from one of our mentees, because they are just great all day long, but if they say it sucks, then that's not a good thing. Thankfully, he did not say it sucks, but I do want to share his comment. He said he's had a good experience. He said that having a mentor has helped to flatten the steep learning curve for those in residency. I've been able to learn from the experience of my mentor without making the same errors. And I wasn't expecting that, but I think that is valuable feedback, that a mentor, they can share, so you don't have to make the errors that they did that took them 3 to 7 years to find out. You can know it now. And there's been a lot of positive feedback from those who have attended our quarterly meetings. And kind of a thing that has happened that we didn't expect is that not only have we gathered a following of residents and fellows, but also underrepresented staff and students and grad students who really like the content that we're offering. And there are 2 outcomes that we're working on. They are areas of opportunity. And that is, it's hard to get residents free from duty to attend our meetings, and that's just because of their role. And as a coordinator, I know how important it is and the moving parts involved in getting them released from duty. And so that is something that we're working on. And I think it's also, of course, considering their curriculum, but it's also considering making it a culture, making it a priority in the institution to allow them to be released from duty as they would any other educational session. And the other thing that is an area of opportunity is we have more faculty mentors than mentees, which I think is a good problem to have, but it's, again, something we are working on, because we want faculty mentors to stay engaged until they do get matched with someone in the program.
Wow, that's a lot of information, good information. Thank you so much. Tina, do you have
Well,
a follow-up
I have a
question?
comment from the chat. Before that, I just want to comment on what Artina described, because there was a lot of good information and what all of you are talking about. I'm trying to take amped notes here. But I think you pointed out to something that is so important as well, and that is the today we have, a lot of, luckily, more and more efforts are going on to address this issue, right? But there's one thing that I hear people mention, and that is that, as an individual, you still come out intentional organisms and processes are not aligned. And I think Dr. Brown was talking about the alignment early on. I think that is so important, that everything has to be aligned within an organization. So there's all these things that have to kind of like and be thought through. So is this organization actually reinforcing diversity and inclusion and addressing things like Laura mentioned, things like that actively, or are we still kind of like implicitly counting on the individual to take action and solve this, right? Which it has to be a joint effort. So that was just my comment and thought. But I wanted to see if you could just share the name of the, there's a comment in the chat box from Miriam Schwartz about who offers the active bystander training, and if you could just share that again. And you could either put that in the chat box or just say it.
Okay, sure. Our Office of Inclusion and Diversity at Wake Forest Baptist Health, the Chief VP and Inclusion Diversity Officer is Dr. David McIntosh. And if you'd like, I would be happy to connect you to via email. But it's he and manager Montez Lane Brown who developed this this training session. And when they initially started it, which I think is about 2 years ago, they had a session, the trainers session, because it's a bit aggressive for them to be able to enlist other people across the institution who had a heart for this to be a trainer as well. And there is the train the trainer session, and there's a protocol and documents that are involved. But yes, I'm happy to connect anyone that would like to be connected.
Okay, thanks. That's good information. Continue to see that COVID-19 disproportionately affects African Americans, Latinx folks. It's just crazy what's going on here. On July 8th, North Carolina DHHS announced that they were going to ramp up the testing, and I included a little blurb there in our notes, and I'm wondering if you all have noticed any other entities getting involved in this. So I want to come back to Dr. Smith, and maybe you know about this in your community, because I know that you've got a lot of underserved folks down there. First Health is your hospital, and you've also got some Indians down there, I think, as well, right? The Lumbees are kind of in your area.
Yes, and the testing efforts, we have had private entities to step in and assist with testing. And Robeson County, which does have a very large Lumbee Native American Indian population, they actually were able to have testing done early on, which was very good to identify, as well as in our own community. The Harris Teeter Corporation offered testing for not only our community, but also Greensboro and Charleston, South Carolina. It was interesting in that we were able to review some comparative data. But one of the things that, and I want to point out with testing, where we were seeing disparities in access, is not all of the private offices had patients who were in our panels. We had to kind of struggle a little bit to get the testing. I think also when we look at the distribution of how the testing was done, there was definitely not equal access, and so that created a problem. I wanted to highlight beyond that of testing is the three-part. There's testing, and then there's tracing of those individuals who test positive, and then treatment, and then hopefully seeing some type of change in behavior that would prevent individuals from having increased exposure or increased risk to coming down with the coronavirus. And so those three components was a major issue, particularly with tracing and educating the population of the need to ask questions. Some felt were intrusive because that's part of it. And so we had to be careful who were the individuals who were participating in these roles and what was their background in terms of understanding cultural differences and understanding where bias may have entered into the discussion, therefore turning that person off, and they were not going to share any of their information. That is a barrier in terms of trying to control the spread of the virus. And so I just wanted to highlight that, those 3 points of testing, tracing, and treatment, that all along that spectrum, we are seeing differences. And I'm very concerned if we really impact in terms of controlling coronavirus, we really need to look at those 3 aspects individually.
And Michaela, as the population health manager there for Dr. Smith's practice, I wanted to get you involved in this answer, because Dr. Smith talked about contact tracing and, of course, treatment and how that should work. And I'm wondering if in your data that you're collecting as a population health manager, there's some other things that you could suggest that would be useful.
Yeah, absolutely. I think it's imperative that it's where we're trying to do these mass testing efforts that we get buy-in, because just when interacting with a lot of our patients here, there was already a distrust to the testing itself, and so the tracing, I could see how that is existing as well. And so, you know, we tell them that Harris Teeter has set up a testing site that's on Saturday. All you have to do is drive through, and then some of the responses would be, well, if Dr. Smith or I don't feel comfortable, so I'd rather come to the office and have that test done there. So I think just making sure that the local entities in those communities, especially like ours, where it's rural, it's small, the SES, it can sometimes be a little bit declined, if you will. So we're dealing with, you know, literacy, high illiteracy levels, a lack of access, like Dr. Smith has mentioned. And so building reputations and building a relationship with those patients are so imperative to ensuring that they have positive health outcomes, because they have built a level of trust with their providers to ensure. I think that it's a great initiative. I definitely feel like it's needed. I feel like our patients would benefit, our community would benefit, but I just want to encourage that we're reaching out to our local providers, our local health entities who are working with our population to ensure that, and that our patients have an understanding of this isn't some outside person just trying to come in and steal your health information, because you'd be surprised idea that a lot of our patients hold. So I just want to make sure that that's taken into consideration when things like this are being sent out into communities where there's a need.
Thanks. And Dr. Brown, I do want to get you to chime in on this, given that you're, as in your position, you're doing a lot of stuff with the medical center down there and in the community. So my guess is that you guys have got an infrastructure for testing and tracing and treatment. Can you talk about what you guys are doing?
We're not in as good a shape as what we would like to be. We have a real problem with our public health here. Our health department is doing a total of 160 tests per week, which is woefully inadequate, and we're doing several thousand in the remainder of the private medical community. And we are able to do a fair job of testing and tracking those patients, but we have some access problems now because particularly in the Hispanic community, and it's really unexpected the way this is developing, right? Because we've gone out into the Hispanic community and really worked with them rigorously around the right practices to prevent COVID and also testing. But with a lot of the businesses, what's happened is that even if it's multiple crews and they're working at different sites, if I'm in COVID, then basically a lot of the employers are asking everybody to get tested before they can return to work, which is a disaster because they have to find their way to get testing. Many of them don't even meet indications to truly need testing, and at the same time, they can't feed their family and put a roof over their head. So our problems are more on the side of the deficiency of public health, and they don't have the testers and trackers adequate to the need. Some of the other places in the region are better, and Goshen, the FQHC that's in the more rural areas, has done some really good things with some mobile testing and tracking in places. But this is still a real challenge for us in all populations. Frankly, the necessary resources for the tracking and tracing piece are the real challenge at this point in time.
Thank you, sir. Tina, I think you have a question.
Yeah, there's a question, an important question that was posted a little bit ago. So how are your efforts to advocate for racial equity in healthcare affected by the three white barriers: privilege, fragility, rage, that are commonly encountered in other settings?
Okay. And so I think our ability to advocate, one is to certainly be part of those discussions where we have already established those relationships, to be part of our organizations, to be part of these, our associations, to start to raise the awareness of those individuals who we've been working with for so many years, and try to finally get our point heard. I appreciated my colleague who attended Duke, and I graduated Duke in 1984, and listening to that noted is very interesting. And I can tell you that I was able to sit down and have a lunch break with the chancellor, and we spoke about these very same issues back in 1984. Still seeing the same trends, and I was surprised, not surprised, but just listening to her. And so I think our advocacy roles are going to be, we have that opportunity, but we're also going to need to put forth some effort when we attend our meetings, when we attend those discussions, to be a little bit mindful of this is an opportunity where we can make a difference, and we can now put those issues on the table. Yes, there have been barriers because oftentimes we know that, oh, that doesn't matter, or that doesn't have impact here, or perhaps that is not within our purview. That is not the desire of this organization to take on health equity. We're quite frankly trying to maintain the survival of our practices, and health equity is not an issue that we are willing to just tell me how to earn more money and how to open. Not recognizing that if you don't take on these issues, that yes, you will see some less optimal performances of your clinical practice and your organization.
Yeah, and I see several people are nodding. Artina, did you want to comment on that?
I think these a lot of times are the elephants, and it's kind of like shade off of a fresh sore. You know, you don't want to take it off because it's going to hurt. And so I think it's, you know, we just have to be courageous, and already mentioned that, and have these conversations, because if the behaviors fall into these realms, then that's what it is, and we address it as such. There are scholarly writings on these aspects, especially privilege and fragility. So it's a thing, and I guess one of the ways that I think would be good to address it is to go from an academic perspective. I think people would be slightly more willing to recognize that they exhibit these characteristics if you come from an academic perspective, because there's data to show it. And I think they are barriers, but I don't think they're insurmountable. I think you just have to be bold to be able to address it in a respectful but firm way, to say this is what it is. These are very appropriate changes. If you're going to do what you say you're going to do to make changes, we have to address it and kind of leave it in their court.
Yeah, I think I mean, we can't do anything before. We can't, if we don't label it, we won't be able to address it, right? So we have to talk openly. I want to just add to, Dr. DeCruz is adding to his comment and says the terms, check out YouTube videos, and then it's called White Rage, Carol Anderson. And then of course, I'm sure most people here are maybe reading the book or have read the book called White Fragility by Robin DiAngelo, which is an awesome book. I just started it, and it's probably a book everybody should read. Dr. Brown commented he encounters each of his circle for sure, and then it's so true, and unless we call out on these, we will never break that cycle, right? So it's so important that we do. And then we have another question. Any thoughts about getting an outside group to evaluate the racial inequalities at our facilities and help the clinicians and healthcare employees address the issue?
There's definitely a role for that, because it's one of the transparency, and you can take it from at the patient care level. First thing you have to have is the right information to understand what disparities are. You know, if you haven't properly input the right race, ethnicity, and language information, you can't tell if you have a disparity or not. And one of the things that's really, I think, a powerful lever in sort of fighting there's a barrier to talking about white supremacy in medicine, right? I mean, there just is, because it makes people think that they're not doing a good job, and it goes to the defensiveness, and then all of a sudden it's hard to get anywhere. But if we were able to break down our systems to really transparently demonstrate those differential outcomes, it becomes unassailable at that point. And then we create a space to have a different discussion, because by all means, we need to have different discussions. And one thing that I've been working a lot in our community to try to understand, and it's a process, this current situation as if it was a cancer. What's the primary, right? And I've seen some analogies around racism as the primary tumor. I don't think so. I think the primary tumor is probably white supremacy. And we've begun exploring this idea. I'm not sure if it's right or not, but the truth is that if you think about it along the cancer metaphor, if you're complete resection of that cancer, if you don't get it all, it's going to come back. And if you look at all racial progress that we've made in the country over time, and the recidivism that have come from attacking it from those angles, you see that obviously there are other pieces of that tumor that we haven't gotten out. And right now, we still can't even talk about white supremacy in many circles, in most circles. We have to be able to get there, because it's really that misinterpretation that makes these things come back every time. It continues to come back every time if somehow I'm allowed to think that, you know, my way right in the best way. It's not. We don't know what the best way is until we have those discussions. And to me, that's somehow what people like me that have positions of influence in communities and in organizations have to be able to get that out into the dialogue. And once it's there, the ability to make progress is remarkably enhanced. We found that in certain pockets of what we're in our community and in our organization. And so I think we have to, as a society, as a medical society, as a starting point, we have to take this on. We have to how we're living into that, whether we want to or not. And we can debate that till the cows come home, but that debate is inconsequential, because it's more about the results that you're getting than what your intent is. And so if we can get this and really scrutinize our policy, make some very meaningful, big resections of things that we can see that are wrong, then the chemotherapy part of it, along the cancer metaphor, is that we really have to then interrogate all the policies, all of them, and find out not what their intent was, but what are they driving. And then we have to administer that chemotherapy and really get at all those policies. And when we clean those up, we got to have surveillance. So after we've completed our course of treatment, we've got to have our surveillance. So when we assess that policy, eradicated that policy, and put a new policy in its place, did it do what we thought it would do? Or did it perpetuate something else because we might? So that's the surveillance part of post-cancer treatment. And I think that if we, once we get correct, that white supremacy is if it's not the primary, it's part of the tumor of racism that is inextricable. And so it's got to be resected at the same time. The the metaphorical way that we're trying to address it down here and talk to providers, because that helps them think of it in a different way. And we've had some success, but it's an uphill battle, quite frankly, because people they become so defensive. They become so defensive. And the final thing I'll say, I'm sorry for taking so much time, is that I think the important thing to understand about this is what it means to be responsible. And so I'm here to say I'm taking full responsibility for all of it. And by that, what I mean is that responsibility from the root words just means the ability to respond. Doesn't necessarily mean I caused it. It means I have the ability to respond. And if we all take our respond and apply it with a relentlessness, then we can get there.
Thank you so much. I think it's these conversations are so important, and what I think we're realizing as well, Frank and I, as we're sitting here, is like we probably would need much more time, which is why we need to have this conversation. And I love how we're daring to go more into actually talking about what we need to talk about towards that. But I think that's what we absolutely need to do, and that is our responsibility, I think, for having this power hour that we need to facilitate as well. So I want to thank you all for that. We're coming up on time. I wanted to see if there was any one of the other guests that had a comment to add to that. Or if you just quickly wanted to add anything, or I'm going to hand it over to Franklin, as we want to be mindful of your time as well.
Well, I will say that the North Carolina Medical Society is both on this topic, and we appreciate it, and we look forward to more conversations. Thanks,
Karen. I want to thank all my guests today for continuing this discussion that we started last month. And as Tina said, we're going to continue to pound away at this. And as Dr. Brown said, we're going to have a lot of courage and, do a lot of difficult stuff that's going to make some people uncomfortable, but we need to knock down some walls on this and make some progress. So I want to thank you guys a ton for all this. I hope you all have a great weekend. Thanks everybody that's been listening and participating today. Have a good weekend.